Hello. Hello and welcome to a new edition of our Leading in Complex Times Conversations. My name is Carlos Luca and I am the head of operations of the Center for the Governance of Change, which is an applied research center that studies the political, the economic, and social implications of the technological revolution. At our center, we have a series of research projects on data and privacy, on cryptocurrencies, or on geopolitics of artificial intelligence, among others. And today we are honored to have with us the research director of one of our programs, the Future of Healthcare Research Program, Mireia Crispin. Hello, Mireia.
Hi, Carlos. It's great to be here.
So Mireia is a biomedical science fellow at the University of Cambridge and at Cancer Research UK. And she also previously worked at Memorial Sloan Kettering Cancer Center in New York, as well as the Large Hadron Collider at CERN in Geneva. She holds a PhD in physics from the University of Oxford, and her work focuses mainly on machine learning models of response to treatment based on medical images. So Mireia's program at our center looks into how artificial intelligence and other technologies are reshaping the healthcare landscape in Europe. And today she will help us understand how the global dimension of the current health crisis has provided a good ground for technologies such as artificial intelligence or data mining to develop much faster than expected. And she will also talk about how these technologies can help fight the pandemic. So as Mireia will tell you, all these advances look very promising, but it's true that the challenges associated to them cannot be underestimated. Because here we're not talking only about technical challenges, but also regulation challenges, public policy challenges, or even social challenges related to personal privacy or data sharing. So we are very excited to have the possibility to discuss these topics with an expert such as Mireia. I'll briefly explain the structure of the talk. Mireia will now give a 20-30 minute presentation of the subject. In the meantime, you're very welcome to submit your questions through the chat. And after the presentation, we will have a Q&A with her where she'll try to reply to all your questions. So without further ado, please, Mireia, take it away. The floor is yours.
Thank you, Carlos. Well, thanks for the invitation to speak today, and thank you very much for the introduction. What I'm going to do is share my screen so that you can see some images that I wanted to share with you. So if you just give me 2 seconds, hopefully you will be able to see my screen. So in theory, you should not be able to see it, hopefully. There you go. So as Carlos was saying, I mean, the interest in AI has been growing massively in the last few years, and in particular in healthcare. But what we've seen with the COVID-19 crisis is that it has achieved really unprecedented levels. And I know that all of us here have been following the news very closely, very intensely. And because of that, I thought that perhaps a good starting point would be a graph that I am sure all of us are very familiar with, which is, as you probably guessed, the salmon-colored graphs that John Byrne-Murdoch has been producing in the FT. And I think that these graphs, updated every day with new data from countries all around the world and shared instantly through social media, are really a symbol of this pandemic. Because it's being really one that's heavily based on constant tracking, digital media, the development of models, predictions, and underlying all of that, the expectation that data would be readily available to answer many of the most pressing questions. And so I wanted to start talking about data sharing, because it's really the foundation for AI technologies, but it is also typically one of the biggest hurdles. And with COVID-19, what we're seeing is a huge and unprecedented effort to push it forward. And this visualization that I'm going to show you here is perhaps less known than the FT graphs, but it's one of my absolute favorites. And it's coming from a website called NextStrain. And NextStrain, what it does is it's providing real-time snapshots, really like a video, as you can see there, of the evolution of the genomics of pathogen populations. And they provide these data visualizations to virologists, to epidemiologists, public health officials, really anyone who needs that information. All of the tools are open source. And at the moment, there are thousands of complete genomes already available. And this is a number that's increasing by the hundreds every day. And to me, this is a great example of what is really unique about the technological component of this pandemic, which is that we're talking about very advanced technology, for example, the whole genome sequencing of a virus, combined with the rapid deployment, sharing of analysis, visualization, in a real feat of international collaboration. And I'm going to speed this up so you can see what happens a bit later on in time, but you can really see very nicely all of the interconnections across the world and the true global dimension of this pandemic, thanks to this very advanced data visualization tool. So in another really extraordinary feat of data sharing and rapid analysis, there was a team at the University of Oxford called the Data Lab. And they recently analyzed the electronic health records of more than 17 million patients in the UK through a project called Open Safely, as you can see there on the screen. And all of their software is open, again, for security review, for scientific review, for reuse. And the nice thing about it is that they actually don't transfer the data. What they transfer is the code to the place where the data is stored. And thanks to that, they've been able to make really rapid progress. So I think that they completed all of this research in just 5 weeks. And the sheer size of the data has allowed them to get some really interesting insights into the main risk factors of the disease, which is what you're seeing in that figure on the right. So for example, you can see if I zoom into it, you can see that there's a very clear dependence on the obesity for the risk hazard ratios. And something similar, again, very interesting, is being seen for the deprivation index. So again, really interesting insights that are being obtained thanks to this push for data sharing at a really large scale. Another example of data sharing is what's happening with images. So here I have the example of a European initiative, the Imaging COVID-19 AI project that was again set up, I think, in only about a week. And it includes data sharing across Europe. I think it's 20 or 30 different partner institutions, which include Spain, Italy, and some of the most affected areas. And again, the idea here is to train an AI algorithm that will be able to detect COVID-19 on the images. But it's actually not just medical data as such that is being pooled and analyzed. Another great example is the data set from Kaggle. So Kaggle is a very successful software competition platform where data scientists around the world upload their best algorithms to answer the questions. And what they did about a month and a half or 2 ago, it was to compile a data set of 47,000 journal articles about COVID-19 and other coronaviruses that are related to it, in order to answer all sorts of questions about the disease, including transmission, incubation, risk factors, etc., using natural language processing and machine learning techniques. And I think I cannot end without mentioning what is probably in a lot of people's minds at the moment, which is the question of contact tracing, which is now becoming automatic. And it's again another example of a very advanced technology coupled with important strides in terms of deployment and data sharing, with some caveats, of course, that we will discuss later on. And so just so we all know what we're talking about here, when I talk about automatic contact tracing, I'm referring to the apps that use a technology such as Bluetooth, which logs an entry when 2 smartphone owners are close to each other. such that if someone develops COVID-19 symptoms, then an alert can be sent to the other users that may have also been infected as a result of that contact. Now, the question is, how is that data is stored and shared? And it's a matter of controversy, and different people, different countries are doing different things. So basically, there are two main models that are being followed, the centralized and the decentralized. And under the centralized model, the anonymized data that is gathered is uploaded to a remote server, which analyzes the data and then decides who's been in contact with whom, etc. And by contrast, the decentralized model it basically gives the users control of the data. The phones are the ones that gather all of the information necessary, and they're the ones that make the call. So this technology is evolving fast, but of course, as we all know, there is no consensus yet, and we'll talk more about that a bit later on. So with data being gathered and shared so quickly, the ground is laid out for predictive modeling to flourish. And I'd like to use the word predictive modeling instead of AI here, because firstly, because it sounds a bit more down to earth and explanatory. And secondly, because it reminds you that what we're doing is to develop models capable of predicting outcomes when given new data inputs. And so just very briefly, we'll do a bit of a machine learning reminder. So what do we mean by predictive modeling and by training an algorithm? And the basic idea is basically what you see here on this slide, which is that a model is given some data as input, and that data is annotated. So for example, if you're trying to classify these different figures of different fruits, they will have a label next to it. So you have a figure of an apple and the label of an apple, etc. So the algorithm can see both things at the same time. And so as a result, after the training, when you give it a new image without a label, the algorithm will be able to predict the right label. And so this is the most basic idea, and is the concept known as supervised machine learning. But in fact, algorithms can work in more complicated ways. For example, by being able to process sequences of data and their interconnections, as in the case of natural language processing, in which what you give to the algorithm is actually an entire sentence with different elements that have interconnections between them. So how are these algorithms being applied for COVID-19? The answer is actually they're being used everywhere in a lot of different areas. And again, I wanted to give you a flavor for where that is happening. So a very interesting example is one provided by a company called Ancora that existed before COVID. And what they do is they use natural language processing models to sort through all of the eligibility criteria of clinical trials. But now they've also incorporated the COVID trials, and they actually recently reached the milestone of 1,000 COVID trials, as you can see here on the graph. And what people do is they fill out a questionnaire, and then the tool will will pass through all of the information about the clinical trials, and they will alert you when there is one that is available for you or that they think should be good for you. Again, for the clinical trials that are included in the database, some of them also have components that depend on AI. And an example here is one clinical trial that was sort of generated by a company called Benevolent AI. They focus on drug discovery, and what they have is a model that's based on a knowledge graph, which is something like what is drawn here on the screen. It's essentially a large repository of medical information, structured medical information, that is extracted from scientific literature, so basically from papers. That's how they create the graphs. And so what they did was to fine-tune the algorithm to search for approved drugs that could help with COVID-19. And they focused on the ones that they thought might be able to block the viral infection process, which is composed of several steps, as you see here on the graph. And so by doing that, they identified baricitinib, which they predicted would be able to reduce the ability of the virus to infect the lung cells. And that drug is actually now being trialed in the United States. So again, another example of how AI can help with this process. We've already talked about imaging, how it's being used. A great example is a company called Cure.ai, which has developed a technology that they claim is now being used in 28 sites across the world to help with COVID-19. And it's an interesting example because what they did was, instead of creating an entirely new algorithm purposed specifically for COVID-19, was to take another tool that they had developed before and had tested in 1 million images, if I'm not mistaken. And that is a tool that looks for abnormalities that are not necessarily, so they're not COVID-19 in itself. They are signs of COVID-19. There are types of abnormalities that you might see in other patients with other types of disease, but that are also shared by patients with COVID-19. And so by doing that, they benefit from being able to use larger data sets and essentially repurpose an existing tool. And this is really interesting, because it helps you against the biases that might come from using a very reduced kind of short-term kind of data set. And again, we'll talk about that in a minute. And finally, the other area where these models are being used is, of course, epidemiology and risk prediction. And as two quick examples, I had the Blue Dot example. So this is a company that specializes in risk prediction. And so what they do is they scan over something like 100,000 official and media sources in something like 60 or 65 languages every day. And that way they can track how diseases spread. They also check flight itineraries, they check the weather and so on. And so they're able to come up with a risk score that they communicate to the relevant stakeholders. And the interesting thing, the reason why I'm mentioning it here is that, according to what they say, they were actually they were one of the first ones to alert of the presence of this new disease in China. And they actually published what is believed to be the very first scientific paper on an unknown etiology in Wuhan, China. So it was, again, these digital tools that allowed them to be so quick in the detection. And finally, the curves that we all see all the time, looking at how the number of infected cases are evolving, or the number of deaths. And of course, not all of these models include AI. Some of them are incredibly simple in the way they work. Some of them are more mechanistic. Some do include AI. And the reason I'm including these particular figures here is that these come from the American Center for Disease Control, which is one of the institutions that is giving out a lot of the information these days. So a lot of the data that we all see actually comes from the CDC, their recommendations and so on. And they usually include a few models. And this one in particular is usually one of the ones that gives the best predictions, or the best agreement with what is actually happening. As you can see there in the bottom graph, that is comparing the real data in yellow with the prediction of the model in blue. And this model, interestingly, does use machine learning to fine-tune some of its parameters. And before we go into the issues, I wanted to mention telemedicine, which is not always AI powered, but it's nonetheless really interesting because it's undergone a tremendous boost out of pure necessity. So for example, the NHS in England, which is the National Health Service here, recommended that GPs switch to face-to-face appointments, change the face-to-face appointments to telephone or video in the month of March. And this is very important for two reasons. One is that it's not simply a tool that is being replaced by a more modern one. What we're seeing is a complete rehauling of a whole care pathway. And secondly, this is something that affects the patients directly. So you as a patient are experiencing something that's very different to what you would normally see, which is not always the case for AI tools. And there's a very clear example, which is a tool called eConsult, again, from the UK. This tool is now being used in almost 3,000 NHS practices. And it's gone from having 300 consultations a month 2 years ago to having 360,000 consultations a month now, which adds up to about 12,000 consultations a day. So again, it's an incredible growth, and the way it works is that the patient will fill out a questionnaire in their mobile phone. That questionnaire gets sent to the practice, and then the practice will decide what to do with it, whether to have a follow-up via video or if they need face-to-face. And of course, they also have an emergency kind of quick response in case anything really bad is detected through the app. Now, this is not in itself AI powered, but it is laying the ground for these types of technologies to flourish. And in fact, there are other apps that do use AI and that have been adapted to deal with COVID-19. And so some examples are, for example, a fertility app called Natural Cycles, which now also includes COVID-19 in the symptoms that they track. And also some bots that normally are used for triaging. So you will you tell them your symptoms and they will tell you what's going on, what you should do. So some examples are Meditor, Babylon. All of these now include COVID-19 specific functions. So I think until here, this is a great or hopefully comprehensive list of the very impressive feats that we've seen in the realm of digital and AI-based health technologies in the context of COVID. And I think there are a lot of reasons to celebrate despite what's going on, in the sense that a lot of these advances would not have been possible just a few years ago, and yet now they are providing us with what could be really vital help against this terrible pandemic. But as Carlos was saying earlier, even at this relatively early stage, there are some warning signs of the risks of this type of very rapid development. And of course, the more complex the task that we're trying to accomplish, the higher the risk. And if the technology and its implementation and integration are rushed, then it becomes even harder to predict and to account for all of the possible consequences, not only at a technical level, but also, as Carlos was saying, at a societal level. And from my point of view, one of the biggest problems, or sort of the most fundamental problems that artificial intelligence models can have, is that of biases, which we've already mentioned a couple of times when we were discussing some of the tools. And the concept of bias can be explained really easily with the same kind of slide that we used to understand what we mean by training an algorithm. And so, for example, if an algorithm only ever sees green pears and red apples when we train it to label a fruit, then the algorithm will go for the simplest thing to look for, which is in this case color. It'll figure out that pears are green, apples are red. And so if I then give it an apple that is green for classification, it's going to get it completely wrong, even though I might have expected from looking at my initial very small data set an accuracy of 100%, because it was doing a great job in the data that I used for training. And yet, when I give it the new input, it fails completely. And so this is essentially what's happening with the biased algorithms. And it's a particularly important issue when the data set that we use for training is small, or when there is a very clear bias in the way that the data was selected. And so as an example, there was one of the first studies that was using CT scans that got a lot of attention in the media due to the very high accuracy that they claimed. Actually, if you look at what they're doing in the study design, you notice that all of the patients that were used in the analysis were suspected to have COVID-19. And this is a very important thing to take into account if the tool is to be used, for example, for screening, because you're only considering patients that already have the disease, right? Or that are suspected to have the disease. So we know that, well, there are studies that suggest that over 50% of the patients who have COVID-19 will have a negative CT study. So you would not find any signs of the disease on the imaging if you look at them in the first days of the disease. And secondly, there are also studies that say that only 50% of the asymptomatic patients will have changes in CT. So although the report is quoting a sensitivity of 97%. If you take all of these effects into account, when applied to the whole population, the real accuracy could really go down all the way to 50% or even lower. And this is just an example of one study, but actually there was a review published last month in one of the leading medical journals that looked at all of the predictive models that had been developed for COVID until that point, which was at that point 30 different studies. And they evaluated the risk of bias, mostly due to the data that they had used. And what they found was that every single one of them was at a high risk of bias. That doesn't necessarily mean that they were useless or that they were completely wrong. It just means that you have to be really careful before you extrapolate that beyond the sort of the context of that particular paper. And of course, this is a rapidly changing arena. The picture might have changed, hopefully now, as time goes by and people have more time to compile better data sets. The scene won't be as terrible as the one that this table shows, but it is nonetheless a very important warning sign. And there are things that can be done. We already discussed it. Some solutions involve using tools that already exist, and in terms of training, instead of training entirely from scratch, you can just take something that already exists and adapt it to the task in hand. So that's the example of the Cure AI model that we discussed earlier. But we just have to, keep in mind that not all models are right. Some of them are wrong. And epidemiology is of course, an extreme example, because it's a very, very difficult area. And we have to keep in mind that a lot of these models are making assumptions. And so they have uncertainties, and sometimes they have to be updated and they have to be improved. So that's just the word of caution. Now, leaving that aside, the second huge area of controversy and of caution is, of course, privacy, which is not in the model, not coming from the model itself, really. It's more about the data, but the data is the main ingredient for these tools. And the thing is that in these conditions of crisis, everyone is more likely to make concessions that would not have been considered acceptable in circumstances that are not like this, that are not part of a crisis. But if we do not have the right protections in place, the problem might continue beyond the scope of the pandemic. And we mentioned contact tracing apps earlier, and I wanted to show you this table here. It was compiled by the MIT Technology Review, and they looked at some of the contact tracing apps that are being developed in various countries, and they ask questions like, is it voluntary, the use of the app? Are there limitations in how the data gets used? So I'm reading columns here, and by limitations, I mean, is it really clear what they're going to use the data for, or are they going to use it for something else? Also, will the data be destroyed after a period of time, or will it be kept? Is the data collection minimized? So does the app collect only the information that it needs to do what it says, or is it collecting more, etc.? So basically concerns related to privacy. And I actually found it really interesting. So if you look, for example, at the column on the limitations in what the data can be used for, it's actually really quite astonishing the number of countries where, according to what is known, there are no limitations, or at least it's not what you would expect from a naive use of the data simply to do what you say you're going to do. So again, something that's concerning that we need to be thinking about. And of course, inaccurate models combined with a certain abuse of privacy will lead not only to failures, but in the long term can result in the loss of credibility and trust of the whole field of using AI for these types of solutions. And the final concern that I wanted to mention is that one size does not fit all. We've seen it in this presentation. the digital and AI applications for health and care as a whole are many and of very diverse nature. And so to start with, the scopes are different. Some of the applications are essentially the replacement of an earlier tool by a more sophisticated AI-based technology. So they will not significantly affect the care pathway. And in other words, the public, us, the patients, may not feel the difference that much necessarily. Some of them, on the other hand, have the potential to completely disrupt the pathway, and as such, they will come with a lot more strings attached, and the risk is very high. So I had as an example here the example of the diagnostic chatbots. So one difference is different scopes. The other difference is different paradigms, and again, an example here is the case of the contact tracing. So that is an example of a single application with multiple paradigms, and we still don't really have a consensus of how it should be done. Another very important difference is the innovation landscape. So this figure is actually from the report that, as Carlos said, we've been doing the program that we will publish next month. And what we've seen is that even within Europe, there are very important geographic differences in terms of the amount of digital health innovation that has been developed in recent years. And as a result of that, different countries have very different innovation landscapes, and therefore different levels of readiness to deal with the sudden integration of these technologies in the rushed context of the pandemic. So to wrap up, given all of this, all of the different issues, the biases, the privacy concerns, the heterogeneity of the landscape, what do we do? All of these questions are really related to how do we define standard protocols that take an AI technology and effectively implement it and integrate it into the system. And in particular, how do we do it when the stakes are so high and the consequences are so important? And so I've included here a graph that was proposed by the Ada Lovelace Institute, which focuses on AI and ethics, particularly for contact tracing apps. But I think actually a lot of this is very relevant for many of these AI applications. And if you follow it, it's supposed to be a flow chart. So if you start from the yellow area, that is the starting point, is the development of legislation and strategy from the government, setting a clear vision, success criteria, and outcomes. Then you move in parallel to the blue area, which is all about demonstrating the efficacy. And so thinking again about the protocols, as I was mentioning earlier, what we need here is protocols that test the reliability from a technical point of view of the tool, the safety, the ethical integrity, and the fairness of the outcome. And very importantly, once all of this is done, we still need to care about the trust, so building trust in the users. And this has to be done by having some kind of institution, a group of advisors is what the Ada Lovelace Institute was recommending. It has to be a constant monitoring and evaluation and a phased implementation strategy that allows us to communicate what's going on to the public, the limitations, the risks, etc. And I wanted to add to this graph what to me is also a very important step in the whole process, especially given the circumstances that we're living now, which is the establishment of an international network that allows us to have cross-disciplinary debate and monitoring, because this is really, we're talking here about very global issues that affect all of our countries. And so it's very important that these are all matters that are discussed on a more global level. All of this sounds ambitious, but I think that it is absolutely key to ensure that this push that we're living now will also translate into long-lasting benefits for patients and for the system as a whole, and not simply an anecdotal thing. And so the aspects that we've been discussing now are only a few of the many different dimensions of the problem, which also include, as you see here, the questions of professional skills and expertise, the public perception, the professional perception, etc. And these are actually all matters that we've studied in the report that we've done in the Future of Healthcare program. So I don't want to go into too much detail because I want to invite you all to attend our presentation, which will be next month, and we'll go into all of these aspects in a lot more detail. But I think it's actually a very natural continuation of what we've been discussing here today. And just to wrap up, I wanted to end with the idea of a new motto. So in the context of AI, we still hear a lot the idea of you move fast and you break things. And there's this XKCD comic that I like that says, you know, these are all of the jobs that you would have been fired from. And unsurprisingly, it includes quite a few healthcare occupations, because it really doesn't work like that in healthcare. And so I just wanted to propose this idea that's a lot more in line with our current view of the world, of a very sustainable idea of cycles and interconnectivity, where we see that data and machine learning advances are actually just the tip of the iceberg, just the tip of the mountain. And they have to result in a pathway that is connected and that is constantly being reviewed, debated, and monitored from an ethical point of view, from a collaborative point of view, from a policy point of view, and of course, all going back to the public and the patient's perception and their benefit. And I think I'm just going to stop here. Thank you very much for listening to that introduction. And I'm looking forward to discussing with Carlos and to reading all of your questions.
Brilliant. Thank you so much, Mireia. It was a very, very, very clear and crisp presentation. Well, we do have a few questions. The first question comes from Bartomeu Montserrat, who asks, if there was another pandemic in 10 years, how will AI help better than it could now? Take into account the developments we're seeing, and what about in 100 years? So I would summarize, and of all the technologies you've been talking about, which one do you think is more promising, or it could be more efficient about the COVID-19? And also, which ones would be more efficient in the long term against other diseases?
Mm-hmm. Yeah, it's a great question. Thank you. So I think one of the key issues that we've had with this pandemic, which we already knew about before, is the sustainability of the way our current healthcare system works. A lot of our systems are overloaded, and that's been one of the main reasons why we've had to take the drastic measures that we've seen in countries across the world. Simply the fact that hospitals were not able to cope with the number of people who needed immediate care. And so I think that is a huge opportunity for digital technologies. Of course, not the only one by any means, but I think that these techniques that make it easier for people to get immediate response, immediate care, whether it is through something like a telemedicine app, so seeing your doctor remotely, but also in time as we validate and derive more models that are based on AI, chatbots or tools that allow you to understand what's going on and what you need to do, can be key in completely changing the way that the system works, and hopefully help it to make it more sustainable and to be able to give better care to everyone.
Great. We have a few other questions. Let's dive into contact tracing, which is one of the most important, and as we've seen with testing, looks like one of the most promising ways of fighting the pandemic. So the question would be, how could we make sure that tools and apps used here to trace infection contact wouldn't be used by groups who wanted to spread misinformation for social distancing? So basically, how do you see privacy issues with these contact tracing apps. And I would say that we need to take into account that there are two different models of apps. There are compulsory apps such as China, and there are voluntary apps such as the ones that are being launched in Europe. So how do you see these evolving?
Yeah. So of course, and this is one of the biggest questions right now. And so the first thing that we all have to remember is that actually at the moment there is no peer-reviewed, published study that compares the effectiveness of these different measures. So we have no gold standard, right? That's the number one thing. Number two is that there are various limitations to these apps, and you've mentioned some of them, which are mostly technical. As you say, the vulnerability of the apps to attack, to fraud, to abuse, it's purely technical. We have ways to deal with these things. Of course, we're not entirely immune. As the technologies evolve and become better protected, the attacks also become worse. So this is something that requires constant monitoring. It's not simply I've released an app that it's secure. You need to constantly make sure that the vulnerabilities do not increase as a result of a breach or the development of another technology that can circumvent some of the protective measures. So to me, that has to be a constant iteration to make sure that the app really is safe. But there are other technical issues as well. There's the imprecision in detecting contact, really what is contact between two people, detecting the distance between the people. And also the other thing is that we're relying on having accurate testing, right? Because the idea is you know that two people have been in contact, and therefore if one is diagnosed with COVID, then the other one is at risk. But in order to make that leap, you need to first know that that first person has been infected. So again, we're relying on widespread, efficient testing. So these are all the technical limitations. And then for the deployment limitations that you've also mentioned, again, at the moment we only have limited evidence, but it's interesting. So in Singapore, for example, there's an app, I can't remember what it's called, like Trace Together, I think it's called, something like that. And it's voluntary, and the proportion of the people who use it is something like 13%. It's actually quite low. But surprisingly, there was a study published by a group in Oxford recently that looked into the efficiency that you would need in an app. So how many people would have to use an app for it to be efficient? And the threshold that they set was about 60%, 60. And they did a survey to go with that calculation. The survey was done in the UK. And they asked people whether they would be willing to download such an app and to use it. And what they found was that the number was about 75% of the people would be willing to download it and use it for the tracking. So I think we'll have to wait and see, basically, is the answer. But as you said correctly, the studies seem to indicate that unless there is a critical number achieved of about 60%, then the effectiveness would not be enough. And of course, what this says is you need to combine these approaches with other ones, not only because of the efficiency of the approach in itself, but also because there's other limitations which we haven't talked about, which are the social limitations. People who are vulnerable, who are excluded if we limit ourselves to only digital technologies, and we have to, that is very important. We have to take that into account when we come up with a holistic approach to tracking and controlling the disease.
Definitely. I mean, I think there is a big layer of complexity with tracing apps, which is basically that there are subsequent steps you need to do. You need to download the app, you need to configure it, you need to open it and use it, and at the end you need to have Bluetooth activated all the time, which reduces the percentage. And I remember seeing figures such as by the end, less than 10% of people with the voluntary app would actually have all these steps complete. But let's move on to regulation, because I think that it's one of the key issues. So my question would be, and there's a few people asking about this, are there any international efforts to regulate AI, especially in the regards to healthcare? Because it's true that governments have been, they've generally had a hard time keeping up with regulating emerging technologies. So who should be pushing for this? And in terms of governance, we have this question by Cristian Manzano. Should there be, in your opinion, a single institution or a single debate to regulate these issues? So basically, in the case of Europe, should be national countries which up till now we've seen that are the ones leading the centrality of the state has been leading the fight against the pandemic, or should be supranational organizations such as the European Union? How do you see this going forward?
Yeah, so great question, and there's a lot of different things that you've touched on. So I'll go one by one. If I forget anything, let me know. So so the question about regulation. So there's several aspects to the regulation. Perhaps the two key ones are the regulation of the data, so the privacy aspects, and then the regulation of the device in itself as a medical device, basically. So in terms of the data privacy, of course, the regulation that is relevant for us is GDPR, and GDPR is still it's applicable to all of these apps. And in fact, the European Parliament published a resolution last month that said specifically that any digital application used in the context of this pandemic had to be in full compliance of the GDPR, so the data protection and privacy legislation. Interestingly, they also said around the same time they published a recommendation that called for a common toolbox for mobile applications, contact tracing, but also actually modeling and predicting, right? So the European Union is trying to push for that, and it makes a lot of sense. So if you ask me, what I think makes sense, as one of the members of the audience were asking, for things like contact tracing, if what you're doing is following a person around, you need to be able to have some consistency in how you follow that person across regions in a country and between countries. We're more connected than ever, and particularly as we relax some of the restrictions that we had during the lockdown, people are going to move more naturally, and so there has to be some kind of consensus. And it's interesting that as the European Parliament was saying, it's not just the contact tracing, it's also how we're modeling the disease, how we are making the predictions, and all of us are seeing this all the time, that different countries are using different criteria to count the number of deaths, etc. As for, you were asking also about the regulation, the other question was so about whether we should have a regulatory body that is somehow
could be a neutral body, for instance, such as an agency.
Yeah. So I mean, for example, medical devices. So we have the CE marking for medical devices, and apps which follow a certain number of criteria, so that fall into some categories. For example, they're being used for diagnosis or to make recommendations and blah, 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 fall into the category of medical devices that have to be regulated according to the CE marking criteria. So that does exist, but it is true that we need, I think we still need more consensus, and it would be ideal to have some kind of international body that is in charge of this. And this is what I was trying to illustrate in this final picture of this kind of cloud that is over everything. The other interesting thing there is that actually different countries are are pushing at different rates. So there are countries like the UK, which are putting a lot of effort into having regulation, recommendations, guidelines for digital and AI technologies, and other countries that are not worried so much about it at this point in time. So I think it is very important to have some kind of institution that will make sure that there is dialogue happening between these different countries and some level of consensus. And interestingly, actually, as part of this resolution that I was mentioning earlier, that was published last month by the EU, not only did they say that we should be aiming for full compliance with GDPR and some kind of common toolbox, but they also called for the creation of a response organization. They called it like the European Health Response organization or mechanism, that would make sure that next time something like this happens, if it ever happens again, we will have a synchronized European response that will be able to deal with all of these aspects. So
definitely. Yeah. So on another topic, Jermaine Wright asks how much of a role would user experience and user interface play in the current development of the apps? Because I mean, it's true that we have seen from your presentation very user-friendly apps and materials, and others that really look much more complex. So how do you see that?
Yeah, so I think there's a lot of evidence now that the design has to be user-centered and user-driven. So in the case of health devices or medical devices, the paradigm now is to have focus groups and contact with clinicians and patients from the very first stage of the design process. Because ultimately, all of these tools will only be successful if they are used, if the patients and the physicians and or the public as a whole, in some of the cases that we've discussed today, are happy using them. And the design of the app is a crucial component. Now, one of the results that we found in our report, the one that we're publishing next month, is that actually people are really interested to be part of this process, particularly patients. If you ask them, they do have an opinion, and they do want to participate. So more and more, I think companies are aware of this and are trying to include that into the design process. And I hope that in the future it'll become even more important.
Definitely. I mean, we are seeing an increased interest and let's say a shift of perception in society with these issues. I mean, just yesterday, the Spanish government presented their seroprevalence study of where basically they studied how many, they tried to understand how many Spaniards had been infected by the COVID. And it turns out that a very high percentage of the people that were contacted were okay with sharing, first of all, their data, but also their blood and physical samples to be. So it looks like there's a shift. Also, I would like to point out that we are at the center, we are publishing a study in a couple of weeks regarding perceptions towards technological change. And we have studied and we asked before the COVID and after the COVID, if Europeans would be okay with sharing their personal data, especially healthcare data. And we've seen a spike and an increase in the people that are willing to share their data. And especially in the hardest hit countries such as Spain and Italy, it's pretty interesting that more than 70% of the Spaniards and the Italians would be okay to have a very restrictive app, such as the one they have in China, which, as you know, is a colored QR app that basically without it you can't go anywhere and you can't move. So it's an interesting shift of paradigm. And I would like to know if you think that this pandemic will be the beginning of a new era in data sharing, because we've seen that, you know, the US and China are leading this, but in a way that Europeans do not, basically they do not agree, because they're, you know, they believe that privacy is I would say even a currency. It's more than a word. It's going to become the next currency. So how do you see these evolving with, you know, after the pandemic?
Yeah. So so I think the key is in what we do now. So what we do with this general feeling of optimism, of technological and digital optimism that the people have at the moment. And this is what I meant earlier in the presentation with be careful with the biases, be careful with the inaccuracies, be careful with abusing the data, because if that leads to failures, then that'll completely break that kind of implicit agreement that we have with the public at the moment, which is, I'm giving you all of this data because I think you're going to do something good with it, right? But the moment you break that trust, particularly with things like health, this could be a huge setback. So I think it is an opportunity, but I think it has to be done well. So I think that's why it's more important than ever to make sure that all of these advancements are followed really closely by policy, by regulation, by monitoring, to make sure that things are done correctly, such that they constitute a real step forward. And indeed, as you say, the basis for a future in which we can use data to our advantage while protecting all of the rights that for us are absolutely fundamental, such as the right to privacy. But I think it's actually another important consideration that we have to remember is that there's likely to be also important heterogeneity in the response. So, you know, you say that 70% of the people-ish are happy to use that app. So who are the other 30%? You know, who are we excluding? And so these are things that we also have to keep in mind all the time, even though we are driven by this impulse to go forward and to use more data and so on. We must not forget that there are communities or vulnerable population that might feel excluded from these technologies.
Definitely. We are unfortunately running out of time, but I think there's time for one last question. I think it would be interesting to talk a bit about the skills and the issue of training and having the right skills for these technological applications. Because what we're seeing is that precisely those industries that need that could benefit more from you know, data sharing and data analytics are the ones, for instance, it comes to mind that the transport and logistics, it is unrelated, but it's true that PricewaterhouseCoopers study evaluated and looked into that. An expert considered that 95% of experts considered that was one of the key industries that could benefit from big data and data analytics. And it turns out that when you actually interviewed people in the sector, it turned out that less than a third of them had the proper skills. So how is the situation in healthcare, and are there any plans or any actions we can take in order to to close the gap?
Yeah, so that's a great question, and again, I'm going to just give you a teaser trailer because this is one of the big questions that we ask in the report. So I'll just give you a couple of ideas. I think it's a very interesting and very important question. In healthcare, as you say, digital training is not the norm. For clinicians, for nurses, for healthcare practitioners in general, digital training is just not part of what they do, mainly because at the moment they don't need it. So it's not that surprising and it's not that widespread just yet. There's opportunity, but we're just not there yet. But there's two interesting results, I think, that suggest that things might be changing. One is that there are already countries that are developing combined degrees. So the figure of the technical doctor, so to speak. So countries like the Netherlands, for example, are already doing that. And these are people who are fully able to train a machine learning model, but who are also fully qualified to treat patients. So it's a very interesting figure. So it's a completely different training pathway. And I think something similar will have to happen in the other areas as well, to have that component in your training. The other interesting result is that actually as some of these areas become more driven by digital technologies and AI and so on, they actually become attractive for other reasons. So we've seen this in a survey which asked people how likely, so these were all doctors by the way, how likely they were to choose a particular discipline such as radiology, which is likely to change as a result of the introduction of AI technologies. And the expectation was that people would say, oh no, I would never go into that because I will lose my job. But in reality, a lot of people would choose that because of the fact that it is going to evolve and it's going to become technological, and therefore, more like future looking in a way. Of course, the task will be different, but it also becomes more attractive just for a different reason. So I think we might also see an evolution in the tasks themselves, and also in the reason why you would choose to have that career in the first place.
Definitely. Well, unfortunately, we have run out of time. Thank you so much, Mireia, for your time. It's been a wonderful conversation. I think participants actually really enjoyed it. We have so many questions that we were not able to respond, but please do visit our website in the coming weeks, because the AI and Future of Healthcare report will be published by the end of June. And well, I think, the COVID pandemic has certainly put a stop to a lot of processes. I mean, I think about global trade or aeronautics or travel. I mean, these are sectors that have been extremely impacted, but it's also speeding up others, such as healthcare. So this is something that organizations and companies need to take into account when thinking about their medium and long-term strategies, and not only about the urgency of the crisis management. So anyway, Mireia, it's been wonderful. Thank you everyone who joined. Please practice physical distancing and wear masks when you are outside. And thank you very much, everyone.
Thank you, Carlos, and thank you, everyone. It's really been great.